Thank you very much for the kind introduction. And I'd like to thank the organizers for the honor of the invitation to speak on this topic in this hybrid conference. So, to start off, just to define, Mdr Tb is defined as TB resistant to the two key first-line anti-TB drugs, rifampicin and isoniazid. And if these two drugs are no longer effective, then the standard 6-month short course regimen can no longer be used, and we will have to then treat the patient with less effective second-line drugs, which are more toxic, more expensive, and which have to be used for a longer period of time, up to 20 to 24 months. So some other definitions here pertaining to the talk and Mdr Tb. Before 2021, XDR Tb, or extensively drug-resistant Tb, was defined as Mdr Tb which was additionally resistant to any fluoroquinolone or second-line injectable drug, which are the two key second-line MDR drugs. And pre-XDR Tb was defined as resistant to either of the two key second-line drugs, fluoroquinolone or second-line injectable. However, since January this year, WHO has redefined XDR Tb and pre-XDR Tb to be in line with the key changes in their recommendations for treatment of Mdr Tb, which were disseminated in 2018. So now, pre-XDR Tb is defined as Mdr Tb, which is additionally resistant to any fluoroquinolone, and XDR Tb defined as Mdr Tb with resistance to fluoroquinolone and either or both of the two group A high priority drugs, betaquilin or linezolid. So before 2020, TB was the top killer from a single infectious disease agent globally. Of course, now it has been far eclipsed by the COVID pandemic, which has greatly disrupted health services globally, especially in low-income, high TB burden countries. So this graph shows that every year, WHO actually estimates 10 million new TB cases, but there's always been a detection and treatment gap of maybe 1/3, which has actually been closing very nicely over the past few decades until last year, when there was a dramatic drop of detected TB cases from 7 million to 5.8 million, 18% drop. And this was due to the disruption of health services, TB services in the high TB burden countries, reversing years of progress that has been made in TB control. As for Mdr Tb, every year WHO estimates to 500,000 cases of MDR or rifampicin resistant cases, of which only sadly about 1/3 are actually detected and treated. Some progress has been made over the last few years in terms of improving the treatment, detection and treatment of these cases. But however, as you can see, the COVID pandemic again has resulted in a drop in the detection of these cases in 2020. So I'm afraid to say that it's actually forecast that for the next couple of years, the effect of the pandemic on TB control is only set to worsen and reverse the progress that has been made over the last decade or so. Okay, what about the rate of TB worldwide, globally? This map shows the global incidence of TB per 100,000 population, and you can see the highest rates are among countries in sub-Saharan Africa and countries in Southeast Asia. And this actually shows the TB incidence rates per 100,000 as given in the latest WHO report released last month. And you can see that many countries in our region have very, very high TB incidence rates. Singapore has the second lowest TB incidence rate in Asia, being second to Japan, which has a very low rate of 12 per 100,000. So what about Singapore? Well, here we are. We are a tiny little island city-state in Southeast Asia, very densely populated with a total population of 5.5 million, which includes 27% long-term pass holders, which comprised mostly transient migrant workers from the surrounding region. Pre-COVID, we were an open economy and a global transportation hub, receiving several million visitors a year, including medical tourists. As regards TB, as I showed you in the last slide, we are an intermediate TB incidence country with an annual rate of 40 per 100,000, as shown in the latest global TB report. So what is the Mdr TB situation in Singapore like? This slide shows the number of cases every year. Fortunately, overall, the number of cases is low in Singapore. You can see that 80% of our cases are foreign-born, and Mdr TB actually constitutes 3% of foreign-born TB cases in Singapore, versus only 0.3% of cases among our local-born TB. Most of the Mdr TB cases are new cases. You can see from this chart that in the years following 2012, there was an increase in the number of new Mdr cases among the local-born, due mostly to a couple of outbreaks, which I will talk about later. So this shows the incidence of Mdr TB in Singapore, diagnosed in Singapore, according to the country of origin of the patient. You can see that in terms of incidence, the highest incidence of Mdr TB occurs in patients from Myanmar at almost 10%, followed by Vietnam. In terms of absolute numbers, the highest number of MDR cases actually come from patients from Indonesia. And in terms of previously treated patients, you can see clearly that people who have been treated for TB before have a higher risk of having Mdr TB. What about for those born in Singapore, Malaysia? Well, our incidence of Mdr TB is fortunately still low, both in our two very closely related countries at 0.3 and 0.4% respectively. So we were able to elucidate the transmission dynamics of Mdr TB in Singapore using mirror VNTR and oligotyping, which were available from 2006. So during the 13-year period, 2006 to 2018, there were 290 Mdr TB cases notified in Singapore. Oops. The majority were foreign-born and were new cases. Half of them were smear positive, 10% were fluoroquinolone-resistant Mdr TB, 2% were XDR TB, defined then as MDR resistant to fluoroquinolone and a second-line injectable drug. So mirror VNTR is oligotyping performed on 287 of these cases, identified 108 cases in 24 clusters, and most of them were of the Beijing strain. When WGS became available in 2016, we were able to apply this retrospectively to 85% of our mirror clustered isolates. And you can see the superior discriminatory power of WGS reduced the number of clustered patients and the number of clusters by 2/3, to 43 cases in 9 clusters. So here I will show you the WGS and mirror clusters. So you can see the mirror clusters are shown in blue bars. And WGS on 85% of these cases significantly reduced the numbers of clustered cases to 43 and the numbers of clusters to 9. And it also redefined one large mirror cluster, cluster G, which comprised patients mostly from the same country of origin. It was redefined by WGS into 3 separate clusters. You can see that among the WGS clusters, a relatively high proportion of cases were among the local-born. So I'll just run through a little bit about these local-born clusters. So the first documented spread of Mdr TB in Singapore occurred in 2011, where the source case was an illegal immigrant who was arrested, and then before he was put into prison, as is routinely done, pre-entry screening X-ray was done, and this showed right upper zone infiltrates. He was sent to TBCU for evaluation, and his sputum was smear 3+. Expert done on the specimen was positive with rifampicin resistance. And he was, of course, started on the appropriate treatment. 2 months later, after his diagnosis, an auxiliary police officer who accompanied remandees to courts and to prisons was diagnosed with Mdr Tb quite shortly after being diagnosed with HIV. And another 3 months later, an HIV positive person who shared the cell with the index case for 48 hours in May manifested with Mdr Tb. And when we tested the isolates or subjected them to mirror VNTR fingerprinting, all 3 isolates belonged to the same strain and had identical profiles. So the following year, as you can, this is the epidemic curve. So these 3 cases all occurred in 2011, but the following year, what happened was that a drinking buddy of one of the HIV Mdr Tb cases was diagnosed with plural Mdr Tb. And later in the same year, and a couple of years later, another 3 Mdr cases arose, who all shared the same DNA fingerprint within this cluster, but the last 3 cases had no known epidemiological links to any of the previous cases. So this shows how Mdr Tb was so-called imported into Singapore and then subsequently spread among our local-born population. Moving on to the next big cluster. This cluster started off with a 26-year-old local-born man who was coughing for many months, several months, before he finally was diagnosed with PTB, smear-positive PTB. But after diagnosis, unfortunately, he defaulted treatment and managed to elude us for another 6 weeks. And by the time he came back for appropriate treatment, you can see the progression of disease in his chest x-rays. Anyway, he was highly smear positive, highly infectious. He was coughing, and actually he had worked at and spent many hours in a LAN gaming center or cyber cafe, and he had lived with his friend and his friend's mother in a public housing unit flat. So what happened was contact screening was done around him when he was diagnosed, and it detected active Mdr Tb in his housemate and in 2 of his close cyber cafe contacts. And later in the same year, Mdr Tb was diagnosed in another 2 young men who were actually not identified as his contacts, but who surfaced nonetheless, and who gave then a history of having patronized the 2 cyber cafes which were actually frequented by the index and his contacts who developed Mdr Tb. And the following year, another Mdr case with the same DNA fingerprint but with no epidemiological link to these patients was diagnosed. And the next year, another 3 Mdr cases with the same DNA fingerprints were diagnosed, one in a cyber cafe patron, another one in a person who lived in the same housing block 2 doors away, and another person with no epidemiological link. In the following year, 2015, another 2 persons who lived in the same housing block developed Mdr Tb, one of them being the housemate's mother who lived in the same unit. And another year later, another Mdr case with the same DNA fingerprint was diagnosed in a residence of the housing block, and this person lived quite far away, but within the housing same block. And the next year, in 2017, another young man who had patronized the effective cyber cafes in 2012 manifested with Mdr with the same DNA fingerprint. So whole genome sequencing showed that the DNA fingerprints or the genetic, all these patients actually had identical genetic fingerprints, and all of the cyber cafe contacts actually were identical in terms of the WGS profiles, and some of the housing block contacts, as well as those with no links, had very closely linked profiles with the index case. So you might wonder, what is that case there, which we label as K? So on questioning, it transpired that our index case had worked in a karaoke lounge at the same time as when a hostess there developed Mdr Tb 4 years ago in 2008. And so 4 years later, he developed PTB, and diagnosis and treatment was delayed for several months. And then He triggered, therefore, the largest outbreak of Mdr Tb in Singapore, which comprised 2 separate large clusters with cases manifesting over a 6-year period. So transmission occurred in a rather unconventional setting, a cyber cafe, which actually was not altogether surprising because of the closed, poorly ventilated environment where the patrons typically spend many hours at a time. But also, transmission was also identified in another unusual setting within a public housing block between people who actually did not have any known interactions with the index case. And thankfully, after 2017, there were no more new cases which arose from this cluster. So WGS not only reduced the number of mirror cluster cases and clusters, it also redefined a large mirror cluster into 3 separate clusters. All but one of the members in this cluster were from the same country, Myanmar. And there were 3 separate clusters, one which comprised members of a religious congregation in a church, another one which was between 2 housemates, and another cluster between a shop owner and a regular customer of the shop. So to summarize, what we've learned from looking at Mdr transmission dynamics, the majority of Mdr Tb cases in Singapore occur among the foreign-born, but the majority of the cases actually had unique WGS profiles. WGS mirror VNTR overestimated clustering, and WGS redefined clusters and showed that a high proportion of clustered patients were actually local born, and also uncovered some unconventional settings for TB transmission. What we found a little bit concerning was that there were actually 15 local-born new Mdr Tb cases with unique WGS profiles. So this raises the question as whether where they could have gotten the Mdr Tb from. Of course, they could have acquired this outside of the country, but we are nevertheless still concerned that there may be Mdr Tb cases which are missed in our country and being transmitted. So let me now just move on to the grade of Mdr Tb among the cases diagnosed in Singapore. So we noticed that there were some differences according to the country of origin as to the severity of Mdr grade. As you can see that a high proportion of patients from Myanmar and Vietnam already are resistant to all 4 first-line drugs, not only just rifampicin isoniazid, but streptomycin, ethambutol, and even pyrazinamide. You can see that patients from Indonesia and Vietnam have higher incidence of fluoroquinolone-resistant Mdr Tb. And you can see that, interestingly, patients originating from Philippines actually had rather a low grade of Mdr Tb, meaning mostly only resistant to rifampicin isoniazid, but also they have a higher incidence of ethionamide resistance compared to cases from the other countries surrounding us in this region. So moving on to Mdr Tb treatment, conventional Mdr Tb treatment is long and difficult, and it requires at least 5 drugs for 20 months. Prior to 2018, you can see that after 2018, after WHO did individual patient data meta-analysis, which showed good results with using the newer drug, bedaquiline, and the repurposed drug, linezolid, WHO actually made key changes to the recommendations for Mdr treatment, such that the drugs were regrouped, such that levofloxacin, bedaquiline, and linezolid are the high priority drugs, followed by clofazimine and cycloserine as Group B drugs, and the other drugs in Group C are ranked according to their harm versus benefit ratio. And you can see that the second-line injectables, kanamycin and capromycin, are no longer recommended in the WHO Mdr treatment guidelines. Recognizing the tremendous challenge and burden of the 20-month regimen to health systems of developing countries, WHO in 2016 recommended a shorter standardized treatment regimen based on observational studies in Bangladesh and African countries. This regimen comprised 7 drugs with very, very high doses used, and it actually resulted in fairly good treatment outcomes for 85% in the observational studies. In 2020, based on favorable outcomes in programs in South Africa, whereby they substituted injectable kanamycin with bedaquiline and moxifloxacin with levofloxacin, WHO recommended replacing the injectable in this short regimen with bedaquiline. So among patients diagnosed with Mdr Tb in Singapore, we looked at the eligibility for this shorter regimen. That was in 2017. And well, an exclusion criteria for this regimen is if the patient is known to be resistant to any of the other 6 drugs besides isoniazid used in the regimen. So looking at our sample of patients, you can see that overall, about 70% of our patients diagnosed in Singapore from around the region are actually resistant to at least one or more of the drugs in the shorter WHO regimen. So this actually gives our patients only eligibility of 30% for this shorter regimen. So, and let me just let you know, we did try this shorter regimen on some of our patients who are eligible, including those with rifampicin monoresistance. And actually, our experience with this regimen was unfortunately not very good. Quite a lot of them had a lot of symptoms, GI symptoms, hypokalemia, hepatotoxicity, prolonged QR or QTc interval. So overall, this regimen was very poorly tolerated among our patients, and basically we have stopped using it since 2017. So now moving on to Mdr Tb treatment outcomes. Globally, treatment outcome for Mdr Tb success rate is around maybe 60%, not good, compared to those who are treated with the first-line regimens, whereby the success rate is about 85%. Nonetheless, there has been improvement in the global TB treatment success rate for MDR patients from about 50% for the 2012 cohort to 59% for the 2018 cohort. By region, you can see, however, that patients in the Southeast Asia region, WHO region, and European regions actually fared worse than those in the African and Western Pacific regions. What about the treatment outcomes in Singapore? Well, I show you the outcome in 69 patients who are citizens and permanent residents whom we treated over the last decade or so. We have managed to achieve a treatment success rate of 88%, but not without having to use the legal act as a last resort in some of the cases. So all the cases were treated under strict DOT, and I'm glad to report that as of to date, there have been no relapses that have occurred among these treated patients. Moving on, I'd just like to say a few words about the use of bedaquiline by our national TB program. So far, we have had to limit the use to selected patients in view of the high cost to the program, because this drug is subjected to a tiered pricing structure. So it is, when it was first being recommended for use by WHO in 2018, the price was $41,000 for the 6-month course. Fortunately, it has come down, and I hope that it will continue to drop the price. Okay. Also, the other reason was that until this year, phenotypic DST for bedaquiline was not available. But so far, we have used it in 12 patients with high-grade MDR or XDR, pre-XDR TB, or patients with side effects or hypersensitivity to the second-line drugs. And actually, the experience with bedaquiline has been very good, has been very well tolerated with good treatment outcomes. So the more recent discovery of predominate and its use in combination with bedaquiline has raised hopes of simplifying and shortening MDR treatment regimens. And so far, there have been 2 phase 3 trials with results reported. And it shows that this combination, together with linezolid and with moxifloxacin in the TB practical study given for 6 months, has produced excellent treatment outcome of almost 90% favorable outcomes. So this is indeed a game changer and has given new hope to our MDR TB patients. So I'd like to end my talk by reminding us of some basic principles in TB control. Firstly, diagnosis must be made early. For this to happen, one has to have a high index of suspicion of TB and also for Mdr Tb in persons coming from high Mdr Tb incidence regions. So there must be liberal use or widespread access to the rapid molecular tests for genotypic drug resistance so as to detect these cases early. And last but not least, having diagnosed and detected these patients, all efforts must be made to ensure treatment success and to prevent amplification, development of further drug resistance by ensuring treatment adherence. The patient must be treated under strict DOT with good support, ready access to financial and psychosocial support within the framework of a strong TB program. Thank you very much for your kind attention. I would like to also acknowledge and thank my colleagues for their work in TB control during my time when I was director of the TB program in Singapore. Thank you again for your kind attention.
Thank you, Cynthia, for a great talk. And for physicians like us and in different hospitals in Singapore where we make the diagnosis of TB, but then the patients are followed up at TBCU, so we don't really see the complete evolution. And I think these it just shows how complicated things actually are. So we have a couple of questions. One from Gabriel Lian. So what are the treatment regimens for latent TB used in contacts who are exposed to Mdr Tb?
Yes, I anticipated this question, so this is my next slide. Prior to, say, 2018, the recommendations by most TB authorities was just to closely observe Mdr Tb contacts for at least 2 years. So in TBCU, we were following them up 6 monthly with chest x-rays for at least 2 years. However, since 2018, WHO has updated its guidelines based on certain evidence, not randomized controlled, but observational studies on the use of levofloxacin-based preventive treatment regimens, and which actually gave good outcomes. So since 2018 and actually 2019, the international authorities actually do suggest or recommend a 6 to 12 month treatment regimen with levofloxacin with or without accompanying drugs such as ethambutol. Of course, this is based on the source cases susceptibility results and for 6 months. So if you're asking about TBCU, what we're doing now, we are slowly starting to give LTBI Mdr PT using levofloxacin-based regimens.
Yeah. So second question asked by Tuck Hong Cheong is that, TB can be transmitted via the aerosol. So was this the reason maybe for the housing block cases, in all your clusters?
Yeah, so the housing block cluster was very interesting, very unexpected. I think, yes, this patient actually is unusual because he was undiagnosed and untreated for many, many months. So he was very infectious. As to how this infection was transmitted in this housing block, my guess, my speculation is that it could be perhaps in the lift, in the elevator, where I think the air exchange is quite poor and it's a very closed environment, and being a very infectious patient. That's only my speculation.
Okay. One last question by Ms. Lisa. Would you recommend latent TB treatment in previously treated PTB, after a few years, even because the risk could still be present, especially in HIV patients?
You're talking about patients who were previously treated with TB but who are now exposed to an MDR case. Is that what you're asking?
I'm not sure. I just think that, after the TB treatment, because HIV patients are at a continual risk, is there any role for giving them?
Okay, so pertaining to HIV patients,
Yes.
yes, I think there is a role if they are newly exposed to TB. Yes, I think that there is a role for giving them prophylaxis, but I think it's very hard to to decide in someone who has already been prophylaxed before, and then you don't have tools to guide you as to tell you whether they've been reinfected. But I think if there is a certainty of very close exposure in an immunocompromised person such as HIV, yes, I think there is a role for LTPI treatment to be considered.
Probably more with the MDR exposure, right?
Yes, if the exposure is deemed to be very significant. Yes.
Okay, great. So thank you so much. We'll end the talk here. Thanks a lot.